Thanks, Tyler. Welcome and thanks for joining this evening. That's really centered around a discussion about, the lifetime management of aortic stenosis. And look, it's been spurred on by, growing controversies and interest in the potential role of transcatheter aortic valve implantation in this puzzle piece about lifetime management of aortic stenosis, with the expansion of TAVI into low risk and younger populations of patients. We've really seen, exponential growth in TAVI in ever younger populations, perhaps ahead of, available evidence about where it truly fits in the jigsaw puzzle of trying to manage aortic stenosis, particularly for young patients in a lifetime. And tonight we kind of get into some of the big controversies or evolving areas in this discussion, including the emerging data about the long-term durability or not of transcatheter heart valves, and how to manage and transcatheter heart valve failure, and some of the controversies around possibly increased mortality or poor outcomes when failed transcatheter heart valve patients undergo explantation. We're really fortunate to be joined by a guest speaker who is a world-renowned expert in this field, Professor Tsuyoshi Kaneko from the Washington University Medical School, who will be, talking at length about the implications of TAVI as a first valve in lifetime management. And also, look, the piece de resistance of this evening is the second half of this evening, where Dion Stub, myself, and Yoshi will engage in a fairly thorough case-based discussion around some standard, but also some meaty and controversial cases that really highlight some of the evolving areas and areas of controversy at the moment in lifetime management of aortic stenosis. So, look, I really would encourage you to stay for the whole thing, because it just gets better. It gets more and more interesting. And this three-way discussion is really a bit of a piece de resistance for this evening. But really, I think, lifetime management of aortic stenosis really begins with the timing of aortic stenosis intervention and when to start that kind of journey. And in that regard, it's great to have Dion Stub talk about the timing of aortic stenosis. Professor Dion Stub is actually co-host with me this evening. He's really, I think, one of the Renaissance men of cardiology in Australia. He's an interventional cardiologist at the Alfred Hospital. He trained in structural heart under John Webb at St. Paul's Hospital in Vancouver. But since returning to Australia, he's been a tour de force. He's generated original work that spans kind of translational basic science on new materials for heart valves, as well as really provocative, informative, large clinical studies on the practice of TAVI. So Dion, over to you.
Thanks, Martin. Good evening, everyone. Pleasure to have you here. I think from across Australia, very cold in Melbourne, but nice to be chatting and discussing a passion topic of mine, which is aortic stenosis and some of the key decision-making. I'll be kicking off the evening with just 15 minutes, really looking around timing of when do we think we need to intervene, not getting too stuck on how we intervene, that will come later, but really the when. I get grateful support from the NHMRC and have a degree of conflicts around the various device companies. I thought it would be perfect to start the evening really with a tribute to one of the legends of cardiology, Eugene Brunwald, who kind of influenced major spheres of multiple areas of cardiology, but had quite a profound influence on our understanding of aortic stenosis. And it was his seminal paper in 1968, which kind of set the dogma and paradigm, which kind of in the next 10 minutes, I'm going to question, 60 years later, is Brunwald paradigm still valid? And have we moved on from this concept of symptom-driven decision-making? So we're going to look at the natural history, where that history came from, what the evidence is. We're going to discuss the emerging evidence, which is really important around the pathophysiology and remodeling that occurs in the setting of a pressure-loaded heart and aortic stenosis. Is asymptomatic aortic stenosis really benign, which is kind of what Brunwald had taught us all for the last 60 years, how the 4 randomized trials have now spurred the field, where we may be heading when it comes to moderate aortic stenosis, and then how we put it all together. But there's no question that aortic stenosis is a growing problem in Australia and around the world. When it comes to severe valvular heart disease, it dominates the landscape together with mitral regurgitation, but AS is the most prevalent severe valvular heart disease in Australia. It's a disease of aging. So there are varieties for younger patients, but the majority of patients with aortic stenosis are older, which is what informs decision-making. And certainly, as we have an aging population, this has an increased burden. I think one big takeaway from tonight is it doesn't matter whether you look at the observational studies in Australia, Europe, or USA. As a medical community, we are doing a poor job at diagnosing valvular heart disease in particular and aortic stenosis. And so all the studies are telling us that we're missing about 30% of patients with severe symptomatic aortic stenosis. So we can argue when we should intervene on patients with AS. You can't intervene on anyone until you've made the diagnosis. And a big problem is that we're not listening because of the pressures that are put on the whole medical health system. So the stethoscopes are not being used, and then we're not getting the basic echocardiogram just to pick up the disease. Clearly, there are 95-year-olds with advanced dementia that there's a proportion that don't need their aortic stenosis treated, but for significant proportions of this 30%, it's a big problem in the fact that we're missing the diagnosis altogether. For the last 60 years, Brunwald set the stage that taught the theory that aortic stenosis was a benign disease until it became severe, and in particular, until you developed symptoms, with the classic triad of symptoms being the first one being fatigue and lethargy, which is tricky in the setting of aging and often put down to aging, but then the triad being heart failure, angina, and syncope. And once the development of symptomatic severe aortic stenosis, the morbidity and mortality were extreme, with less than 50% of patients being alive at 2 years after the onset of symptoms. And that was clearly judged as the time frame for when we needed to make our decisions, which was once the patient had severe AS with symptoms. I've got fantastic PhD students that have looked at the pathophysiology, defined the various phenotypes that can occur, in particular in the setting of heart failure, which I'll talk about in a moment. But this has been the paradigm for the last 60 years. Class 1 indications for severe symptomatic aortic stenosis, valve area less than 1, gradient more than 4 meters per second, mean gradient more than 40 in the setting of preserved systolic function. I'm not going to talk around the controversies around low flow, low gradient aortic stenosis. Caution when the left ventricular systolic function is diminishing, and again would be a reason to head towards surgery. And then consideration of AVR in patients who are undergoing coronary artery bypass graft surgery anyway. The question that I have for the next few minutes is, in 2026, is it still best practice to wait for our patients with severe aortic stenosis who are asymptomatic to hold off recommending aortic valve replacement, whether that be with surgery or with TAVI, for them to develop symptoms, or for their ejection fraction to fall, or for them to potentially develop irreversible remodeling? And so the question is, why would we consider intervention in someone who is asymptomatic with severe aortic stenosis? And really the things we're looking to do across the field of cardiology and interventions in valvular heart disease is no different, is 1, prevent death, 2, prevent irreversible symptoms, with typically arrhythmia, heart failure being the big ones, irreversible loss of quality of life, and prevent irreversible cardiac damage or remodeling. And so we now have this emerging story where it may not be as clear as Brunwald led us to believe around the benign nature of asymptomatic aortic stenosis. And Philippe Genereux, who works in both Canada and New York, has done some really groundbreaking work around, 1, both the pathophysiology of remodeling in the setting of aortic stenosis, and then questioning the role of earlier intervention. And so there is very clear increasing number of observational series, both in Australia, North America, and Europe, that the staging of cardiac remodeling or cardiac damage at the time of your aortic valve replacement, again, irrespective of whether that's with surgery or with TAVI has major prognostic implications for your next few years. And we have very clear data, both at 30 days, 1 year, and 2 years, that the worse your LV remodeling, and so there's been a few different staging systems. This one's become now kind of predominates. Stage 1 is LV cardiac damage. Stage 2 is with mitral involvement. Stage 3 is pulmonary and tricuspid involvement. And the last stage is when right ventricular involvement in the setting of aortic stenosis, with a clear gradient towards worse outcomes. We know that patients post their AVR, again, TAVI or surgery, some will improve when it comes to remodeling. Many hearts will stay the same, but some we've clearly intervened too late, and that you get even worse remodeling after the aortic valve intervention. So the other clear signal that's arrived is this, over the last 5 years, is this concept of the acute valve syndrome. This is a great play on words that we've taken from our coronary colleagues, where we know that patients with acute coronary syndromes, those that come in with heart attacks, behave very differently to those with stable angina. And it appears to be very similar when it comes to aortic stenosis. Patients who have stable valve syndrome, so severe AS, and undergo surgery, have a very different prognosis over the coming years, and we have very clear data to 2 and 3 years, to those that have progressive valve syndrome, which would be classic symptoms, to acute valve syndrome, those that are presenting acutely, whether it be with troponin rises, BNP rises, or acute heart failure decompensation in hospital. And we have very clear data to show that across this spectrum to stable, progressive, and acute valve syndrome, that your risk of being alive at 2 years is significantly less after your aortic valve replacement. You have significant more heart failure hospitalizations and significant combined worse outcomes with the two. We've done some look at our Melbourne experience across 3 hospitals, Alfred, Cabrini, and Epworth, more than 1,400 TAVI patients over essentially the last 6 or 7 years. And we've shown that 9% of our patients are coming in with this acute valve syndrome and are therefore needing urgent TAVI. Before we had wide access to TAVI, many centres would be doing bridging aortic balloon valvuloplasty. Those days are essentially over. But essentially it shows if you come in with an acute valve syndrome and undergo TAVI, your experience in the next 12 months is very different for our stable elective patients. And there's clearly a cohort of patients that we're either diagnosing too late or leaving too long. And so the question is, from all this observational data, is it really fair that we can still say that asymptomatic severe aortic stenosis is benign? And the observational trials show that survival may be worse, rate of sudden death is higher, and hospitalization and quality of life significantly diminish. So then the question is, where are we at when it comes to randomized trial evidence for earlier intervention in the setting of asymptomatic aortic stenosis versus the traditional paradigm, which is still guideline directed, which means surveillance until the onset of symptoms? We have 4 RCTs. 2 of them were smaller trials that involved surgical aortic valve replacement. One was the combination of surgery and TAVI, and the other was TAVI. Philip's done a beautiful meta-analysis that shows there's been kind of neutral signal towards mortality. So no difference when it comes to mortality, but a clear signal to reduced heart failure hospitalizations, reduced unplanned hospitalizations. And what's very clear across these 4 trials, which is counterintuitive and really quite a new paradigm, is that it is very clear that asymptomatic severe aortic stenosis is a clear risk factor for stroke. And so just in the interest of time, these were the 2 of the smaller studies that looked at younger patients, very severe aortic stenosis. We're talking mean gradients of 50 to 55, surveillance versus surgical aortic valve replacement, and clearly showed benefit to earlier intervention versus surveillance. And then the latest trial, which is the largest to date, which was published in the New England a year ago, was the early TAVR trial. 1,000 patients that were asymptomatic, randomized 1-to-1 TAVI with the SAPIEN 3 or SAPIEN Ultra valve versus standard of care, which is clinical surveillance. Who were the patients? This is an older group to our surgical patients, but still these are very low risk patients from a TAVI perspective. 76, a couple of years older than in our seminal low risk trials. Again, heart team involvement. What's really interesting is these are truly asymptomatic. So that 90% of them had proven asymptomatic status with a stress echocardiogram or treadmill ECG. most of them were tri-leaflet. Again, these are low-risk, anatomically suitable TAVI patients. So again, selected a bit like our low-risk trial that clearly had severe aortic stenosis. We're not talking about potential moderate or lower gradients. This is traditional high gradient severe AS, preserved ejection fraction, and a very clear difference in outcome. Primary outcome was a composite endpoint of death, stroke, or heart failure, hospitalization, very clear difference between the surveillance group versus TAVI. And again, this very clear signal to stroke. When the trial designers the expectation was that stroke would be higher in TAVI, meaning that you would wear the risk of the intervention, but it's very clear that asymptomatic severe aortic stenosis, for a variety of pathophysiological reasons, is a clear risk factor for stroke. I think when it comes to the mortality question, which is really, I think that's still neutral when we look at the meta-analysis across the 4 randomized trials, that the next 2 larger RCTs will be really pivotal to answer that question. Do we really change mortality? It's very clear that we potentially influence morbidity. And so then the kind of follow-on question is, well, if we think asymptomatic severe aortic stenosis now becomes an indication for surgery, should we be looking at potentially more moderate aortic stenosis? And again, Jeff Stranger's team at Ecolab have been seminal in showing that moderate aortic stenosis, when we again look at observational series, potentially does not look benign either. And it may be because of the difficulties of classifying moderate versus severe, and in many patients, when it comes to echo imaging or systolic dysfunction or diastolic dysfunction, it becomes difficult. There is a group of patients that rapidly progress from moderate to severe, and the whole concept of remodeling and cardiac damage, I think, applies to moderate AS as well, potentially not as significantly. Again, we've done some work showing the significant crossover between the epidemic of heart failure with preserved ejection fraction, diastolic heart failure, and aortic stenosis. And again, these 2 conditions hunt together. And so it's very clear that there are a group of patients who tolerate their severe aortic stenosis with no symptoms, but then potentially other groups of patients, in particular with this diastolic phenotype, the HFpEF phenotype, that in the presence of moderate aortic stenosis really have significant, profound reduction in their quality of life and heart failure symptoms. And it may be that this is the group that potentially would derive benefit from earlier intervention in moderate aortic stenosis, but we certainly don't yet have the randomized data to support that, but that is underway. What is clearly interesting is that, again, for 50 years, we thought there was no medical intervention that would attenuate the natural history of AS. But again, we have the first trial of SGLT2 inhibitors that say may have some role in slowing the progression when it comes to our aortic stenosis patients, and again, clearly has benefit in HFpEF. So just in the interest of time, and really excited for our next 2 speakers, that one, we need to do a better job at detection of aortic stenosis, not missing out patients who are older and potentially just putting down their symptoms to lethargy and deconditioning. And we need to do a better job at auscultating and ordering appropriate echocardiography. The classic dogma of waiting for symptoms to develop in the setting of severe aortic stenosis may need to be updated. And that's something that we could talk about. It hasn't yet hit guidelines. Clearly paying attention to cardiac damage, being maybe more sophisticated with our assessment of patients. What's the role of stress echocardiography? What's the role of right heart cath? Needs further investigation. And that it's very clear from now 4 RCTs that in a select group of patients who are asymptomatic but clearly have severe aortic stenosis, we should be considering earlier intervention. And in the setting of moderate aortic stenosis, we still need to wait for significant more data that is on its way over the coming years. And Martin, thank you very much for the introduction. It's my great pleasure for me to finish and to introduce kind of the host of the evening, Professor Martin Ng. He's a coronary and structural leader across Australia. He heads the structural heart program at Macquarie University and has really been instrumental at the bench to bedside research that's been supported by the NHMRC, has won a series of numerous highly prestigious awards in multiple areas of cardiology, but in particular in the fields of transcatheter interventions and new technologies. And great pleasure to have you on the panel, Martin, and to listen to you over the next few minutes.
Thanks, Dion, for a great talk. I'm going to continue to talk and lead up to our robust discussion of lifetime management of aortic stenosis by really talking about what's really been the hot topic of discussion in the last year, which is the latest data as we come close to 10 years of follow-up in large randomized trials with transcatheter aortic valve implantation. I'm going to talk through the evolving evidence, therefore, for TAVI durability. And through that, and for the rest of the evening, we'll be chatting in an interactive fashion about its implications for aortic stenosis therapy. So, look, why are the long-term outcomes from TAVI so important? Look, at the moment, we have at least 20-year data for surgical bioprosthetic aortic valves, and therefore they remain the so-called standard. However, look, this expansion of TAVI into younger and low-risk patients mean that we're applying transcatheter heart valves into patients who will likely, most of them, outlive their index valves. And therefore, understanding long-term outcomes in TAVI recipients compared to surgical aortic valve replacement patients is essential to inform and make a patient-centered decision regarding management of aortic stenosis. And look, I'm going to talk mainly through the two recent studies involving 7-year outcomes for balloon expandable and self-expanding valves. And we're going to look at it through the prism of what these trials are mainly interested in the moment, which is firstly clinical outcomes, mortality, particularly valve-related mortality, and secondly the question of valve function in terms of valve hemodynamics, but also signals of valve failure through looking at valve reintervention. And so the first of the two groups of studies I'm going to talk about is the long-term outcomes from the balloon expandable valves, the Edwards SAPIEN valve. Many of you will know of the PARTNER 3 study, which is a randomized study of TAVI in low-risk individuals. That's defined by an SDS score of less than 4%. Close to 1,000 patients were randomized to TAVI with a SAPIEN 3 valve versus surgical aortic valve replacement. Now, this year in the New England Journal, the 7-year follow-up for this study was published. And to remind people, the baseline characteristics of these patient cohort were fairly well matched. The average age of these patients were around 73. The SDS score was just under 2. And the patient cohort had the usual distribution of comorbidities. Now, this is the primary endpoint for this trial, which is a composite of death, stroke, and rehospitalization. Many people will remember that in the one-year paper, TAVI emerged superior to surgery, which was a kind of remarkable outcome. But every year since then, and out to 7 years, we've seen an ongoing attenuation of that initial advantage. And gradually, surgery is closing that gap. And at 7 years, there is really no significant difference in terms of the primary endpoint. However, as we break this out, all-cause mortality, initially TAVI was associated with lower all-cause mortality than surgery. This numerically crossed with surgery having lower mortality past 3 years. And at 7 years, all-cause mortality is 16.8% amongst surgery recipients versus 19.5% in TAVI recipients, but this is not significant. In terms of stroke, again, TAVI had an early advantage, but over the years, over time, the gap has narrowed such that at 7 years, there is really no difference between the two. The difference now numerically between TAVI and surgery at 7 is really driven by rehospitalization, where TAVI was, again, markedly superior at 1 year, but then there's been a narrowing of this gap and an attenuation of this advantage over time, such as at 7 years, this is no longer significant. So as you can see, over the 7 years since the initiation of the study, in all the three major components of the primary endpoint, there has been actually cumulative more events amongst TAVI recipients than surgery recipients. But still at 7 years, I think there's no statistically significant difference. And these are the additional clinical endpoints. The thing to bear in mind here is that TAVI recipients have higher rates of clinically significant valve thrombosis, 5.7-fold, 2.8% versus 0.5%. But this has not been associated with increased mortality. amongst patients with clinically significant valve thrombosis. However, surgery is associated with significantly higher rates of new onset AF, which we all know about. In terms of hemodynamics, it's pretty much a wash. At 1 year, as at 7 years, the mean gradients of TAVI versus surgical recipients are similar. The aortic valve areas at 1 year and 7 years are also rather similar. And so there is no signal of a hemodynamic disadvantage or advantage for TAVI recipients of a balloon expandable sapien valve. However, paravalvular regurgitation, which has been really for a long time an Achilles heel in TAVI, there was significantly more mild paravalvular regurgitation amongst TAVI recipients, and this has been throughout the study. There is numerically more moderate or greater paravalvular regurgitation, but this was not significant. Now, when you look at patients with mild AR compared to those with no AR, trace AR, out to 7 years, mild AR patients don't appear to have higher mortality. Now, looking at valve failure, there was bioprosthetic valve failure defined as either development of severe stenosis or regurgitation, need for valve reintervention, or bioprosthetic valve-related mortality is not different between surgery and TAVI recipients, and really it's pretty much a wash at 7 years. And also, the rates of aortic valve reintervention are extremely similar. So in terms, I talked about the two things we're interested in. We're interested in clinical outcomes, and we're interested in evidence of bioprosthetic valve failure or performance. In terms of valve hemodynamics and clinical signs of valve failure, there really isn't a disadvantage or advantage amongst TAVI recipients relative to surgery. They seem very similar for recipients of the bioprosthetic of the balloon expandable sapien valve. And so around 3/4 of patients at 7 years for both recipients of TAVI and surgery are alive and free of bioprosthetic valve failure in the PARTNER 3 study. I'll go now to talk about the long-term outcomes amongst recipients of self-expanding valves. And by self-expanding valves, I mainly mean the Evolut, the valve platform by Medtronic. This is a supraannular self-expanding valve, and the Evolut low-risk trial is a randomized trial of around 1,400 patients who are randomized to a recipient of the Evolut self-expanding valve versus surgical aortic valve replacement. So this is a numerically larger trial than the PARTNER 3 trial. This is the baseline characteristics. The average age of these patients is around 74, slightly older than the PARTNER 3 study, and the STS score is around 2, similar to the PARTNER 3 study, with the usual distribution of comorbidities, which are fairly matched between the TAVI and surgery arms. Now, this paper, which is a smaller paper published in JACC than the PARTNER 3 7-year paper, focused on focused on initial increased reintervention. But the headline here is, they're really the primary outcome of this study is all-cause mortality or disabling stroke. Different to the PARTNER 3 study, rehospitalization is not included. Now, for every report thus far in the Evolut low-risk trial, excluding this one, actually TAVI was numerically superior with lower event rates of all-cause mortality or disabling stroke. However, at 5 years, we see a crossover. And even though it's not significant, surgery is now has numerically lower rates of all-cause mortality and stroke in this study. But at 6 years, this is not a statistically significant difference. These are the other key clinical endpoints, and they are different to the PARTNER 3 study. Whereas the PARTNER 3 study showed no disadvantages of new permanent pacemaker implants, recipients of the Evolut valve have higher rates of new permanent pacemaker implants versus patients undergoing surgery, 29.4% versus 13.4%. Patients undergoing surgery have higher rates of new AF, which is consistent with the PARTNER 3 study. Intriguingly, patients undergoing surgery have higher rates of valve endocarditis over time, 3.2% over 1.4%. However, the real controversy in the meat of this report is this discovery that actually rates of valve reintervention at 6 years in this Evolut low-risk trial was significantly higher amongst recipients of TAVI compared to surgery, 6.5% versus 3.6%. This unexpected discovery prompted a further analysis and an extension of this study to partially look at 7-year outcomes. And this is then the breakdown of this reintervention data out to 7 years. There doesn't appear, there is no difference between reintervention for stenosis amongst TAVI recipients versus surgery, 3.6% versus 3.5%. However, you can see here, this is the rates of reintervention due to aortic regurgitation. There appears to be a striking difference here. At 7 years, 1.6% of surgical recipients have had intervention for AR, compared to 5.6%, an almost fourfold higher rate of reintervention. And it's worth pointing out here that, the mechanism of biparasitic valve-related stenosis is thought to be gradual. It occurs over years, over time, whereas AR can be quite acute and maybe related to acute valve leaflet failure. And so, this signal here is currently subject of a lot of discussion and further analysis. Now, in an exploratory analysis, the investigators in this study looked at the potential contributory role of post-dilatation of the evolute valve in the occurrence of this AR. And you will look here, if you look at the rightmost valve here, the evolute R34, you can appreciate what they're trying to talk about here. These evolute valves are hourglass-like valves, and the width at the base of the valve is significantly wider than where the valve leaflets are located, which is at the waist. So in an evolute R34, you have 34 millimeters at the base, but at the waist, it's 10 millimeters smaller at around 24 millimeters. Now, if you try and if an operator tries to post-dilate an evolute R valve with a balloon that's sized to the annulus, you might be using a balloon that's much larger than the waist and thereby causing injury to the valve leaflet itself. This led Medtronic, because after observation of some injury to valve leaflets in AR, this led Medtronic to put a field corrective notice providing instructions for implanters to really limit the size of the post-dilatation valve to limit this injury. Now, when they look at these 7-year outcomes in terms of what's termed as off-guidance post-dilatation, using these larger balloons or off-guidance balloons, these group of patients actually had the largest rate of intervention for AR 7 years, 9.3%. But look, this exploratory analysis only goes perhaps partway to explain this, because patients who had no post-dilatation had a rate of failure reintervention of 4.8%, still much higher than recipients of the surgical aortic valve. So, look, with that, I'd like to go through the key messages at the moment in this evolving story about the long-term outcomes that we have so far for transcatheter aortic valves. The data at 6 to 7 years show that the key, in terms of key clinical events such as mortality, stroke, rehospitalization, the event rates are similar for TAVI recipients compared to recipients of balloon expandable and self-expanding transcatheter valves, specifically the SAPIEN and Evolute valve platforms. In case of balloon expandable valves, there has been an attenuation of the primary endpoint advantage over the entirety of the follow-up, such that you had statistically significant advantage at 1 year, but now each year on, this advantage is eroded, and now it's very similar at 7 years. In the case of the Evolute platform, we see crossover of the primary endpoint events at 5 years, typically rates of events than TAVI. And so this, we will, at the moment at 7 years, there is no difference in key clinical endpoints for both valve platforms compared to surgery, but we'll watch with great interest what happens at 10 years. However, I think the really interesting thing here is that we now see signal for differing re-intervention rates at 7 years. For balloon expandable valves, there really is no signal for increased valve dysfunction or failure. In fact, the rates are very similar in terms of hemodynamics and rates of valve dysfunction or failure between recipients of the SAPIEN valve versus patients undergoing surgery. However, for recipients of the Evolut valve in the low-risk trial, there are significantly higher rates of reintervention for aortic regurgitation observed at 6 and 7 years. And this differing reinterventional signals may indicate for the first time device-specific differences in long-term valve performance. And I think, you know, it was very interesting to look at the 10-year outcomes as where this pans out. Now, I think the important takeaway message is that, you know, with respect to long-term outcomes in TAVI, TAVI is not TAVI. Each valve will have, like in surgery, each valve will have a specific durability signature. And therefore, we can't really generalize the durability of TAVI per se, but really we can look at the durability of each type of valve because each of them will have different clinical performance over a long term. And as such, we really need comprehensive 10-year and greater for key durability endpoints for all transcatheter valve endpoints in order to better inform, you know, lifetime management of aortic stenosis with TAVI versus surgery. So this then leads us to, I guess, the main event for the evening, which is you know, the talk by our guest speaker, Professor Tsuyoshi Kaneko. Tsuyoshi Kaneko is a world-renowned cardiac surgeon, and his career spans uniquely both surgical and transcatheter management of aortic valve disease. He spent 8 years in Harvard Medical School and the Brigham Women's Hospital, and was surgical director of the structural heart program there, as well as director of aortic and endovascular surgery. He's currently the J.M. Schoenberg Chair in Cardiovascular Disease and the Chief of Cardiac Surgery, as well as Director of Division of Cardiothoracic Surgery at the Washington University School of Medicine. Professor Kaneko is the lead author of the Heart Valve Collaborative's Expert Consensus Statement on Transcatheter Heart Valve Explantation, which has been a foundational reference for surgeons managing failed TAVI. He's also led the largest long-term propensity match study for bioprosthetic aortic valves in the Residia tissue study. And so as a surgeon who spans both TAVI and surgical aortic valve replacement, he is uniquely placed to discuss the issue of whether TAVI is a breakthrough procedure or a poison chalice, the implications of a TAVI-first strategy in lifetime management of aortic stenosis. Before we start this talk, I'd like to tell you that this talk will then flow straight into a case-based discussion between Yoshi, myself, and Dion, taking on some really meaty cases to highlight some of the current challenges in lifetime management of aortic stenosis. This discussion really is the centerpiece of this evening. So I'd encourage you to stay right through to the end because I think you will find it really informative. Yoshi couldn't be live with us this evening because of the time difference between here and St. Louis. So we pre-recorded this just last week. So it's just fresh recorded for this evening. So over to Yoshi.
Hi, everyone. And I want to thank Martin and Dion for inviting me to this Australian webinar. My name is Yoshi Kaneko. I am the Division Director for Cardiothoracic Surgery at WashU in St. Louis in the US. And the title that I was given was Breakthrough Procedure or Poison Chalice, the implications of TAVI-first strategy in the lifetime management of aortic stenosis. And I really want to give kudos to Martin and Dion for giving this title of Poison Chalice. And this is what I imagine when I hear about Poison Chalice. This is from Indiana Jones. And I just hope that the implication is not really the TAVI being this way, ending up like this. So I want to start with with what's going on in the United States. This is what we call the aortic valve universe slide. This is a combination of STS and TVT registry. So STS is from cardiac surgery database and TVT registry is from the catheter database. this top blue line is the total of surgical aortic valve replacements that are being performed in the United States. And this includes not just isolated SAVRs, but SAVR plus CABG, aortic root replacements, as well as double valves and triple valves. And this is the number of TAVRs being performed in the US. So now in 2023, the number of TAVRs being performed surpassed 100,000 cases. So there's a lot of TAVR being performed in the US. And this is the median age of TAVR. So when you just look at the median age, back in 2015, when we were doing intermediate risk, it was 83 years old. In 2024, it's 79. So you feel like we're doing a lot of these TAVRs on old age patients. However, there's been several reports that have reported differently. To the left is a report from California State Database. So patients under age 60, 46% of patients were receiving TAVRs. To the right is the Vizient database. This is looking at all insurance in all age group, and 48% of patients under age 65 was receiving TAVR. So just by looking at this, a lot of patients under the age of 65 is receiving TAVR in the US. There's been an updated report from the Vizient database looking at the number of TAVR and SAVR in patients aged under 65, and you can see that the number of concomitant SAVR is increasing while the TAVR trend has been relatively stable, and you can see that in the percentage. But still, 30% of TAVR are being performed in patients under age 65. And these are some of the SAVR numbers that we're seeing. On the other hand, this is from the TVT registry looking at patients aged under 65 versus patients who underwent TAVR in the age of 65 to 80. And in patients before matching, patients who were aged under 65 had worse mortality, whereas patients after propensity matching, they were almost the same. There was no difference between the two. And what this really shows is that the patients who are aged under 65 who's receiving TAVR are much, much sicker. Therefore, the mortality was high. So we are doing it in young but higher risk patients. So this does show that we're not necessarily doing a lot of TAVRs under age 65 who are low risk, but that trend may continue in the future. This is the valve-in-valve forecast study that was done by Philippe Genereux. And what this shows is that after the year 2021, what will the valve-in-valve market will be in the future? And this is the TAV and SAV forecast. Not a lot of growth that is expected. And on the other hand, you expect that there will be a significant growth of TAV and TAV in the future, and we're almost approaching 2027. So we are starting to see it. We have looked at the American CMS, the Medicare population, and this is something that we recently published. The total TAVRs in the CMS population, which is typically over age 65, has been relatively stagnant. But overall, TAVR reintervention has been increasing at a very fast speed. And this is mainly driven by redo TAVRs, as well as TAVR explant. You can see that the redo TAVR curve is much, much steeper. And there is a reason for that. The outcomes of TAV and TAV, this is actually the first series that was reported back in 2020. But even in that first series, the mortality was extremely low. And when you do it in the right way, it's actually a very, very safe procedure, as shown here. This is also a TVT registry paper looking at balloon expandable valve. And when they were propensity matched, the outcomes between the redo TAVR and the native TAVRs were exactly the same at 1 year. And this was also similar when you had redo TAVR immediately after TAVR or late after TAVR. So the timing really didn't matter. So you can see that it's relatively safe. Despite that projection, we're still at an early phase of TAV and TAV. This is from TVT Registry 2024. The number of TAV and TAV performed was 580. And you can see that the actual 30-day mortality of TAV and TAV is a little higher than what was reported in the registry, 3.6% at 30 days, as you can see in 2024. The stroke rate, 2.7%, definitely a little higher than the native TAVR. And you can see that TAV and SAV had numerically lower number. So despite the optimism of TAV and TAV in the beginning when it first started, the actual real-world numbers look a little worse. So what are the challenges and the problems of redo TAVRs? First of all, it's the different combinations of TAV and TAV. You can just say TAV and TAV, but there are a lot of different combinations. Balloon expandable valve followed by balloon expandable valve, self-expanding valve followed by balloon expandable valve, self-expanding followed by balloon expandable valve, self-expanding followed by self-expanding. There are multiple combinations that really is present, and depending on that, you have to alter the sizing of the valve as well as the positioning of the valve as well. And this creates a lot of challenge in understanding what to do. And also, there are valves that are no longer used. This is the Lotus valve, Boston Scientific Lotus valve. But those valves fail also, and when they come back, you have to be thinking about a different combination. So nowadays, I think the categorization for these TAV and TAVs are split into these 4 categories. So tall and short, short and short, short and tall, and tall and tall. But regardless of the different types, the biggest problem will be the sinus sequestration. So sinus sequestration means that if you put a second TAVR valve into the index TAVR valve, it can actually obstruct at the ST junction, therefore prevent the flow into the coronary arteries. As you can easily imagine, because of where the leaflet lies, the sinus sequestration risk becomes higher in patients who received self-expanding valve the first time. And the risk of sinus sequestration in the earlier studies have been shown to be somewhere between 20 to 40%, depending on the type of valve that you utilize. The third challenge is the impact of the index TAVR. So we have learned over the years, when we do the index TAVR, you want to implant that TAVR valve high so that the pacemaker becomes much, much lower. However, for redo TAVR, if the valve is implanted shallower, the risk of sinus sequestration becomes lower compared to valves that are implanted almost 100 and 0, which can obstruct that sinotubular junction. So it is a balance between the future risk of redo TAVRs and the risk of pacemaker at the time of index TAVR. And some of this could be predicted using the DASI simulations or other AI software using a CT scan. And this will become very, very critical in the future. But if you have sinus sequestration, what about just doing a electrocautery procedures? People have looked at that. One of the key feature is that unless if you have a commissural alignment, no matter what kind of leaflet laceration you do, this does become a problem. This is from the Emory group looking at leaflet laceration, but if the commissural tab is right malaligned in front of the coronaries, there will still continue to be an obstruction. So the commissural alignment becomes extremely important. Also, the leaflet opening after the after basilica procedure, you can see is very, very small compared to the surgical leaflets. And therefore, some of the effect of the leaflet laceration may not be as effective. Also, there's some concern about using a shortcut in this population, and also there's some talk about using balloon-assisted basilica. So more to come in this population. I think the most important combination that we really have to think about, and the most difficulty, the highest difficulty, is putting a balloon expandable valve in self-expanding valve. The neoskirt, which is where the plane becomes after the new valve gets put in, the neoskirt height does change based on where you implant the valve itself. So if you implant the valve at node 4, the neoskirt becomes lower compared to placing at node 6. However, the radius of the implantation becomes the highest at the node 5. It does make it much bigger. So I think all these details matter at the time of implant. And a lot of the TAV and TAV favors placing the valve at node 5 if possible for this reason. Another feature that is very unique to TAV and TAV is the leaflet overhanging. If you implant the valve very low, the original leaflet still may be present, and that the effect of that is unknown at this time. This is a little bit of a busy slide, so I'm going to summarize it. But the valve expansion and redo TAVR is extremely important. This is a paper from Mount Sinai, but all first TAVR was underexpanded. So doing a pre-dilatation and post-dilatation matters. And the second valve, the TAV and TAV, was also underexpanded despite post-dilatation. And it is critical to perform this second dilatation to make sure that the valve is fully expanded. And I think there will be more to come in this space. Again, I think the AI simulation will be critical in the future. You can see that in this case, the risk of coronary obstruction will be extremely low. But you can also guess where to place in the original TAVR to make sure that future TAVR is feasible. So what happens if the TAV and TAV is not possible? This is the number of TAVR explants that are being performed in the United States. Now it's reaching about 1,000 cases, but the problem has been that the mortality of the TAVR explant has been nearly 14%. So the risk is relatively high. So in what kind of cases would TAVR explant be critical? Because as I showed, the mortality of TAV and TAV was about 2%, whereas the TAVR explant at this moment is about 14%. So number one, if you have endocarditis, there has been some reports of this being treated with TAV and TAV with antibiotic treatment. But in general, you do want to remove that prosthesis. And this is the endocarditis versus non-endocarditis comparison in explant TAVR registry. There was no difference between the outcomes between endocarditis and non-endocarditis. So for these cases, TAVR explant will definitely have a significant role. The second role for TAVR explant is if you have sinus sequestration. We showed the sinus sequestration patients, and we show that the percentage could be 25 to 40%. And in these cases, you can do a basilica or shortcut, but the easiest way is to actually remove the prosthesis, because once you remove that TAVR valve, the sinus sequestration risk will no longer be present. The third, but very important, is the patient prosthesis mismatch. This is from the SMART trial in a small annulus patient. But there was 10% risk of patient prosthesis mismatch even in the self-expanding valve, whereas the balloon expandable valve, the patient prosthesis mismatch risk was 43%, as you can see here. And this is one of my own case. Back in the days, we had a patient that had the valve area of 307. The patient received TAVR, and this was the post-implant CT scan. The area of the valve is 188 square centimeters. So the more you implant, the smaller it becomes, as you can see with this Russian doll. It literally is a Russian doll. The more you implant, the valve does get small. The valve area does get smaller and smaller with the stem frame and the cuff. So One of the pros of the TAVR explant is that once you remove, you can actually do a root enlargement. In this particular case, I performed the Y enlargement, and before this was a 23 millimeter valve, we were able to place a 25 millimeter valve at the end with very minimal gradient. Last but not the least, I think the very important need and the role for TAVR explant is the need for concomitant procedures. There are a lot of patients that require concomitant surgery. This is the patients who underwent TAVR with the percentage of mitral regurgitation. So depending on the series, some of this was a clinical trial. So severe MR was excluded, but you can see that up to 30% of patients who undergo TAVR has moderate to severe mitral regurgitation. And if these patients are low risk, they probably will benefit from a surgical procedure. To the right is percentage with mitral stenosis, especially in the elderly. Up to 20% of patients will need concomitant procedure. So we have worked hard as a community to really educate the TAVR explant to reduce the TAVR explant mortality. We did a webinar. There's an app within the Redo TAVR app. We published, invited expert review to talk about the techniques. And as a result, we are seeing some decrease in the number of mortality. These are low volume hospitals and high volume hospitals. And when we compare the two, in the early era, there was a difference in the 30-day mortality. However, in the recent era, that has disappeared. And overall, there's no difference between high volume centers and low volume centers. However, when you compare it with a complex TAVR explant surgery, there still is a difference between the two. So unless if they're extremely complex, a lot of these TAVR explants now can be done at much, much lower mortality. And this is shown by some of the recent series. This is from Michigan. The recent era, the mortality was 5.6%. And this is from University of Alabama, which showed 6% mortality. And there may be more to this. This is some of the earlier studies that we did back in the days using the CMS. The 30-day mortality was higher with TAVR explant, as we know. But in a large registry, after 1 month, the mortality of Redo TAVR and TAVR explant was almost equivalent. So what this really tells you is that you really want to make sure that Redo TAVR or TAVR explant, whichever is the right therapy, should be applied to the patient. And that really emphasizes the importance of lifetime management. We're not going to have time to talk about this, but patients who have really, really long life expectancy, Ross procedure and mechanical valve is an extremely important tool. But for patients who have long life expectancy, this TAVR first strategy followed by either TAVR explant or Redo TAVR with even further potential to receive a third intervention is something that we have to think in this era. Thank you for listening, and I look forward to the discussion.
Well, Yoshi, thanks so much for joining our webinar about lifetime management of aortic stenosis. It's really an honor to have you being part of this event. And look, I mean, I think Dion and I would say that we really enjoyed that talk. I mean, it's been a long time since I've seen Indiana Jones, but oh my God, that was just hilarious opening and very appropriate to the title. And then thank you for, sharing a lot of cutting edge data with us. I guess, I think TAVR or TAVI, it's going through a cycle of the way we experience new technologies where, we have unbridled enthusiasm, a lot of expansion of use. I mean, we've seen 20 years of growth in year after year in TAVI, new indications, new expansion, new groups of populations. And if we've gone to low risk and embrace it more, perhaps now there's this signal, particularly with possibly increased mortality with TAVR explantation, that now we see in the mainstream media perhaps this reaction against this growth that we see with a lot of new technologies, or maybe every new technology. And we're at this kind of point now where maybe for the first time in TAVR history, we may be having a pause and think about, whether it continues to expand. Is your view about TAVR explantation, you show that the outcomes are getting better. Do you think there's a scope for it to become as safe as redo AVR? Or will it always be, do you think, a more risky premise?
Yeah, thanks, Martin. And, I really have to say thank you for inviting me to this webinar. And you guys are very creative on the title. So that Indiana Jones clip came from your title that you gave me. So I got to thank you for that. And I think to your question, in the beginning, the reason why TAVR explant had such a high mortality was, number one, I don't think the surgeons really knew how to do it. It was something new for us, right? And people would take it out and injure the aorta, and inadvertently you will end up with a bigger, unexpected type of surgery. That was part of the reason when we first started. But now I think a lot of the risks are related to the patient cohort. So, patient comes in really sick with LV-RV dysfunction. No matter what you do, I think that patient's risk is going to be very, very high. And when we're talking about lifetime management, I think the group that we're focused on are these young, low-risk patients who receive TAVR at a younger age. What happens when they come back? If they continue to be in that low-risk cohort with not a lot of other comorbidities, especially cardiac, I think the mortality could really be low at this time, especially in the future with all the understandings of how to take it out and all that. So it will really depend on the patient risk at the time of. And one thing that I didn't talk about was, the guideline in the US and Europeans both recommend annual follow-up of these TAVR valves. I don't think a lot of us are doing that. And that will also detect some of these degenerations at early phase rather than waiting until they have LV-RV dysfunction. And I think that's also a critical point that we really need to push as this technology really gets expanded.
Yoshi, you brought up so many good points there. Could we drill down on just that choice of first valve procedure? Because I think that some of the big themes I'm taking out of tonight is, one, the importance of the heart team, and then increasingly we have well-informed patients, so we need to juggle then the combination of shared decision-making with our patients who come with kind of expectations before they walk into the room. But how do you handle in the US that getting that first valve procedure right in our younger group of patients?
That's a very, very difficult question, Dion, and thank you for that. There are relatively straightforward cases, like if you have a bicuspid aortic valve with an aneurysm. I think those are relatively easy. You want to go ahead and do AVR and ascending because you don't want to leave that aneurysm alone. But I think when the age gets closer to 65, which is the cutoff that we have in the U.S. guidelines, in a non-bicuspid patients, I think that selection becomes extremely hard for certain patients. One of the things that we have learned over time is that the TAVR risk is more related to anatomy. The SAVR risk is more related to the patient risk. And I think we have to keep that in mind. So if you really have a young, low risk patients who has high risk features for TAVR, like a RAF-A with potential for annular injury or PVL, those patients should definitely go for surgery. And if they don't have that feature, then I think we're looking at things like patient prosthesis mismatch and the future possibility of reintervention through a transcatheter pathway. And I think all of that has to come in conjunction with patient consulting. And we must not forget some of the other options like mechanical valves and Rosses. So for really younger patients, that really comes into the picture. So we tried to have that discussion within the heart team, and we tried to decide the final plan based on that.
Well, Yoshi, this is a good segue for our heart team discussion. I think Dion and I have a few patients to maybe show and discuss these kind of scenarios. I mean, because you raised this particular scenario, the last scenario raised, I thought I would just show you, I think, a case I've prepared, which is, actually, this is actually essentially a recent patient of mine. He's 51. He's a very, he's a professional. He works full time. He exercises a lot. Like, I mean, this guy is running. He has vigorous exercise. And he finds that, in his exercise routine, in his running, he gets exertional angina, which prompts a visit to a cardiologist. And he's found to have severe bicuspid aortic stenosis, Sievers type 1, fusion of right and left coronary cusps. Ascending aorta is not dilated, normal coronaries. So very low comorbidity individual. He's a professional man. He goes to his cardiologist and he goes like, look, I heard that I can have a TAVR now, right? I don't want to have surgery. And actually, so, by the way, this is his valve. So very heavily calcified. You can see some fusion there. Like, probably not very attractive for a TAVR, actually. What would you be, I guess, what would Dion and Yoshi, what were your thoughts about, what would you advise this man? He comes to your office, he goes like, I don't want to have surgery. Maybe I can have a TAVR.
Maybe I'll start, Yoshi.
Please.
I think this is increasingly becoming an issue that the patients come into our office, whether it be valve disease, coronary disease, with they're well read and their neighbour has had a procedure and they come in with presupposed ideas. I think the first point to make is, Yoshi brought up before around decision making regarding anatomy, that until you have all the anatomical information, and so often the patients want to know the answer about what you're going to recommend before they've had their planning CT or before they've had their diagnostic angiography. And I really focus on just telling them we can't have any discussions about planned procedures until we get all the information, and in particular the CT and the angiogram are obviously crucial. The echoes is done. With this gentleman, 51-year-old, healthy, professional, very active, lifetime management and getting your first valve procedure right will be crucial. And so managing expectations, I spend quite a bit of time highlighting why TAVI will not be a good option for this patient. And the more nuanced and difficult decision is, I think, most centers around the world would be sending this patient for surgical aortic valve replacement, but then it's what type of surgical aortic valve replacement. I'd be fascinated to talk to Yoshi about, many young active patients want to avoid a mechanical aortic valve replacement due to the necessitating lifelong warfarin. So something like the Ross procedure, I'd be strongly thinking, and I bring this up in my young active, patients like this, and then think about choosing a surgeon who's happy about the possibilities of the Ross.
No, I think you answered my question, or you stole my thunder in a way. But I think that's very important. And from the anatomical standpoint in bicuspid, this is not really a great anatomy for bicuspid undergoing TAVRs. With all the calcifications and calcification of the raphe. So, that's one thing that I would probably sway away from. The choice between mechanical and bio, the Jack paper that it was in the presentation, mechanical valves do have a better survival in patients under 60 with less reinterventions. And, I will throw that data to the patients. But at the same time, if the patient does not want to take warfarin, then, that is patient's preference, which is a class 1 indication. So we will respect that. I will definitely put the option of Ross in their table at 51. Right now, the guidelines are up to 50, but I think at our center, we do it up to 60 years old. And a lot of the places in the US are now expanding it to 60 if they're low risk patients. And I know that Australia has very skilled surgeons that has expertise in ROS that they have been doing for a long period of time with excellent results. So I think that definitely will be an option. And for this patient in particular, I would probably push for ROS pretty strongly, saying that there's a potential life expectancy benefit compared to the other options.
So you bring up Ross here, and how many people? I guess this I guess your suitability for Ross depends on your pulmonary valve and other things as well.
Yeah.
How many people in this young cohort as a whole who would be suitable for Ross when they're screened?
Yeah. I think in the US over the last year, we did about 1,000 Rosses in the whole country. And we've done over 100,000 TAVRs and 60,000 SAVRs. So the cohorts are relatively small. But in the right population, I think this is a very important surgery. So,
And Yoshi, maybe just for the audience, just tell them why the ROS, what are the key benefits to the ROS over the other bioprosthetic or mechanical?
Yes. So the benefit of the ROS is that because you implant your own pulmonic valve into the aortic position, the hemodynamic tends to be excellent. No matter what you put in, if it's a bioprosthesis or even mechanical valves, the gradient usually on the echo is about, 10, 8 or 9 at best. When you do a ROS, you consistently get gradients of 2 and 3s. So the hemodynamics are just excellent. And there's been multiple series, including randomized control study, that has shown that after ROS, the survival becomes equivalent to the general public, whereas the bio or mechanical valves, they still have a survival penalty after these surgeries. So that's why a lot of patients advocate for, or a lot of the surgeons advocate for ROS for younger patients. On the other hand, the mortality is higher compared to isolated SAVRs. I think that's a fact. And also, if you need reintervention, you're talking about double valve. There's 2 valves that may potentially need reintervention in the future. So there's a downside to ROS as well. And I usually lay that out to the patients when we talk to them.
Yoshi.
Thanks for that, Yoshi. That was great. I guess, I think it's, you point out, I think in the large ROS series, the 20 on 20, there are multiple ones now that have gone 20 years, 25 years. They're very impressive in showing only single digit, 8% reintervention rate out at 2 decades. So I think you're right. I think in this particular gentleman who exercises vigorously and is therefore not keen for anticoagulation, if he's suitable for ROS, this is a good thing. Otherwise, I think in Australia, if he doesn't want anticoagulation, he's most likely to get a bioprosthesis. I think we all agree, looking at the anatomy, he's a bicuspid patient where TAVR is not a good solution. Dion, any comments there?
How we juggle the shared decision making. It was Yoshi highlighted beautifully how patients very much get to choose between a bioprosthetic or a mechanical based on their desires to take lifelong warfarin. Except we seem to treat it slightly differently when they're deciding between a TAVR or a SAVR. We're a bit more paternalistic with our 50-year-old patients, and it's just that balancing the patient's wishes about avoiding potentially open heart surgery and then what we might think is best in the long run. That can be tricky, and that's obviously influencing the rates of younger patients having TAVI. It doesn't seem to be as much of an issue in Australia with very young, patients under 60 having TAVI, but I suspect those numbers will climb as the patient cohorts kind of demand it.
So, okay. Onto this second case, right? So this is a 66-year-old woman with very severe symptomatic aortic stenosis. You can see the indices there. Minor coronary disease, and really very, very well. Very few comorbidities. She's the CEO a business, comes in, says, look, I can't really, my business is very competitive. I need a minimally invasive procedure. I want to get to work, with the least delay. She's got tricuspid aortic stenosis. Any comments here? Any thoughts when she comes to your office, Dion?
So, Martin, this is a this is a healthy 66-year-old, minimally comorbid with severe symptomatic aortic stenosis. First bit of discussion would be around timing and need for an aortic valve replacement. I think that's clear. I would urge against being too detailed with regards to SAVR versus TAVI until she'd completed an anatomical workup with a CT, because I think that changes the discussion completely. Both the team and the patient can be looking forward to a TAVI. You do the CT and realize that you have narrow sinuses and very low coronaries, and TAVI becomes high risk, and we would be a low risk SAVR patient, and vice versa. You can get surprised sometimes with porcelain aortas, where SAVR becomes complicated. And so, but once the CT's been done, and many times patients are suitable for both, then it's really up to the concept of thinking about lifetime management and shared decision making with the patient, going through the pros and cons. But at 66, you would be, and you're going to have a bioprosthetic valve put in anyway, regardless of TAVI or SAVR. That in my practice in Melbourne, these patients are often going for TAVI. In particular, I think with female patients, both Australian and US data does show perioperative risks of SAVR are increased when it comes to bleeding, patient prosthesis mismatch. So TAVI will potentially be a very good option.
Yoshi, I guess the US is leading the way in terms of TAVI in younger patients, particularly under 70. What are your comments about this case?
Well, this is actually a scenario that we see very often. I love the fact that you guys put the CEO. It's almost like, rich Americans can buy anything and, want to buy their way into TAVI type of scenario. But there are other scenarios, like, they have to take care of their husband, their sick husband, and they can't really leave. I think there's a cohort of patients who would prefer a fast recovery at their life phase, which is their priority. And I think this cohort fits into that. This scenario fits into that cohort. And I think we have to be very careful in this cohort, because we have to think about a lot of things. One thing that we will do is definitely get a CAT scan, and like Dion said, but we actually will use aggressively assimilation software in these cases. So, what happens if we put a TAVR valve in the first time? And can you do a second TAVR valve safely without needing a TAVR explant? I think this is a cohort that we really have to think about that carefully, because, if we do SAVR the first time, this person's risk is 1%. If you do a TAVR explant, no matter what series you look at, the risk is going to be 3 to 5% at the lowest cohort. So we will extensively investigate that possibility. And then also, looking at things like bicuspids, this patient's tricuspid valve, but bicuspids, and then things like patient prosthesis mismatch, we will definitely investigate. But if the patient is a good anatomical candidate for TAVR with future TAV and TAV option, I would certainly explore the route of TAVR. I think that's a very important option for these patients.
So Yoshi, I think you raised several things here. I think in a young patient here, this patient will likely outlive their bioprosthetic valve. So I think these days a heart team really has to think about the next step. And I mean, so this is the virtual CT simulation of this particular patient. So, she has a tricuspid, very heavily calcified valve, but no hostile features for TAVR. So we've simulated a Sapien 326 valve here. And then you can see the coronary heights, at an 80/20 implant, The valve stent doesn't extend to the left main. She's got, and it doesn't extend obviously above the sinotubular junction. So what is your impression about, a redo, just looking at that as a redo TAVR kind of opportunity for this patient?
Yeah, from the coronary standpoint, we don't see the right side, but
It's fine also on the right side.
Yeah, assuming that's okay, I think this is a great candidate. I think the valve size also matters, making sure there's no patient-prosthesis mismatch. But for an executive whose anatomy's really good for TAVR, as long as I think these options are possible, I think it is very reasonable to think about TAVR in these cohorts.
So,
and Martin, I was going to say, just again, whether it be TAVI or SAVR, choosing that right valve for the first implant. So you've simulated a short frame valve,
yes,
low pacemaker rate, maintains coronary access, and allows us more straightforward TAV in TAV option. Just thinking about that first choice of valve becomes really important.
Indeed. So now, Dion, let's say we do this virtual simulation, but actually, the left main's kind of low. We do a virtual ring to coronary distance, which is, I guess, for those who are not familiar, is an assessment for coronary obstruction with the TAVI in TAVI or valve in valve, and like the virtual ring to coronary distance is like 3 millimeters. And the device might even extend up to the sinotubular junction because the sinus heights are low. So these kind of things become, these features become high risk for a valve-in-valve procedure. How would you think about this case then? Would it change what you would do?
Yeah, I think it should. It depends on the patient to begin with. So it's different if you have a 65-year-old with a degree of frailty and comorbidity, life expectancy, future life expectancy may be lower, and your ability or your preponderance to take on risk for the initial procedure may be quite different to this patient who is high functioning, no comorbidities. We know whilst she doesn't want to have the extended recovery of open heart surgery, she's going to do really well with a SAVR procedure. So that when I'm thinking about, am I taking on TAVI for this patient, I want it to be what I would consider type A TAVI, where the initial procedure is straightforward and low risk. If it's more that we're thinking about what's going to happen in 8 to 10 years' time, that becomes a bit more complicated in that, cardiology and TAVI may be one of the few operations in medicine where we're starting to think about, at our initial procedure, do we need to think about what we're going to do in a decade's time, where we know technology change, patient change. So I think, but it definitely making a good initial valve choice and thinking about TAV in TAV options is important.
No, so Yoshi, what if this patient has narrow sinuses, this virtual implant shows very narrow, low virtual ring to coronary distance, low sinus heights, all these worrying features for a TAV in TAV. What might you advise the patient in that situation?
Yeah, in that case, I would probably push a little stronger for SAVR in this case. And the rationale will be that, some of the surgical valves, there's good durability data. So I think we can present that to the patient saying that, these certain types of valves will have a follow-up up to 15, 20 years with relatively low reintervention risk. And I think that's something that we need to talk about. Also, there are ways to augment the sinus so that the future reintervention, when the patient comes back, will become TAV and SAV. And we will speak that to the patients that we might be able to do that to accommodate in the future when the patient's older and sicker. And I think at the end of the day, you throw all these information to the patients, and then they ultimately decide. We have to remember, some of the patient preference after really throwing out all the information, it's very difficult to reverse. And this particular patient, it's sort of a gray zone. It's not black and white like your first scenario. I think the first scenario, if we push for TAVR, despite patients wanting it, I think that's a hard one to defend. But this one, if the TAV and TAV risk is really, really low, TAV and TAV possibility is low, but you can do the first TAVR in a safe fashion, that does become a little more gray, not black and white like the first scenario. So I would throw out all those information to the patients and just understand what's important for them and then make that decision.
Now, you raised the issue of aortic root enlargement and sort of making a space for a bigger valve, but maybe making it suitable in after surgical aortic valve replacement for a transcatheter valve to sit in it. I guess that's becoming, I guess, part of what surgical AVR is in our contemporary practice, right? Are you always thinking about the possibility when you're doing a surgical aortic valve replacement, making room for the transcatheter valve, particularly in a younger patient?
Yeah, I try to think about it, but I'll be very honest. Am I doing it all the time? I'll be very honest. I don't do it all the time because there's always additional risk when you do something like that. And augmenting the sinus sometimes cannot be that straightforward. Ideally, if you augment the left and the right sinus, that'll make a bigger room, which will allow you to do future TAV and SAV much, much easier. But in between that left and right sinus, that's where the left main runs. So, people do get a little scared on that. What happens if you bleed from that location? It becomes very difficult. So, it's sort of a balance in those cases. But I think for certain patients that is someone that I aggressively do is patients that potentially will have patient-prosthesis mismatch. So those I will aggressively enlarge because that's one of the benefits that surgery has.
So let's go to a third case. Now, this might even be actually that first patient after he had his bioprosthetic aortic valve in his 50s. In his early 50s. And, he got a perimount, let's say he got perimount 23, and now he's got a critically stenosed bioprosthetic valve at 62. He had a SAVR with around a decade ago for bicuspid AS. Unfortunately, his SAVR experience was complicated by an ocular stroke post-op. So, though he's since made a reasonable recovery, in the workup, he was found to have a non-obstructive coronary disease with a 50% mid-circumflex stenosis. Now, he and his cardiologist, they call you, they come to you and they go like, look, he's really not keen to have a redo operation because he didn't enjoy his first operation and it was quite a traumatic experience for him. So Dion, any comments here? Any initial thoughts?
Well, I think that the first point is this is a great illustration of why lifetime management is so important, and putting in bioprosthetic valves into 50-year-olds inevitably lead to this clinical scenario where they return anywhere from 5 to 10 years later. And we know, whilst the modern bioprosthetic valves are excellent with regards to longevity, the younger you are when you have it, the quicker you wear out your valve. And you may come back as soon as, 5 to 8 years. And so making that decision, for a 50-year-old, really, you need to think about putting in any type of bioprosthetic valve, because we're faced now with another procedure at 62. And we still, we want to get this gentleman into his late 80s, and how are we going to do that? But that experience after their first operation really informs the patient's decision making. And so many times I have patients who walk in saying, Dion, it really was quite traumatic, my open heart surgery, and I just can't face doing that again. And in particular, if they've had even a small post-operative complication, but a small ocular stroke can be dramatic to the patient with long-term implications. And so many times they kind of walk in with already decided. So I think talking through those options, but a a valve-in-valve TAVI here, again, we need to do the appropriate workup, becomes a very reasonable scenario.
Yoshi, any comments there?
Yeah, I mean it's a little concerning that the valve failed in 9 years. Like Dion said, the patient was young, so if this guy has another Paramount, there's a good chance that it'll last longer than 9 years. But that just shows you some of the limitations of the valve that we have. This is if you throw this scenario at these national meetings, a lot of people will say, oh, we should do surgery on this patient because the patient's number one, not a low risk, not a high risk patients. In the US, valve-in-valve TAVR, TAV and SAV is only approved for high risk patients. This is not a high risk patient by any means. So if we go to the national meeting, everybody will say that this patient should get surgery. But nationally in the US, there's about 6,000 TAV and SAVs being performed every year. Less than 1,000 repeat SAVRs are being done. So in reality, I think a lot of patients like this is receiving TAV and SAV at this time. There's been several people that has raised concerns about the durability of TAVR and SAVR, TAV and SAV. They're not the same with the TAVR durability because of the pinwheeling and now full expansion of the valve itself. I don't think there's any good data beyond 5 years at this time. So doing it on these younger patients, I personally have a little bit of concern. And as a matter of fact, I think there is a randomized control study that is ongoing in this group. So repeat trial. I think Australians were also asked to participate. I know that, yeah.
Yeah, so on that, I'm actually we are actually the lead site actually of Repeat in Australia, and I think you're part of Repeat too. And
Yes.
to raise that, I mean, I guess it's being run, for those who don't know, Repeat is the first trial randomizing people with failed biprosthetic aortic valves under the age of 75 to redo a SAVR versus transcatheter aortic valve in valve implantation. The Leipzig group, as a lead up to this, did this systematic analysis. There's been no randomized of all observational studies, and they show that valve-in-valve TAVI has a lower 30-day mortality, but actually in midterm follow-up, it starts sort of favoring SAVR in terms of mortality, though this is not a statistically significant outcome. And in fact, it's kind of, insignificant, but there is this signal that, perhaps in the longer term, redo SAVR may win out, and hence there is now this randomized study. Now, pertinent to the patient we discussed, I mean, he's got this, he's an average sized man, body surface area of 2, height of 1.75 centimeters. He's got a 23 perimount. Not the largest valve. I guess a lot of the time he might end up actually with something like a toll valve, right? Like a Evolut 26. And then so let's fast forward, he then gets restenosis of that valve, Yoshi, and he shows up in your practice in his early 70s. And now he's got like a failed transcatheter valve inside his bioprosthetic surgical valve, and it's a toll prosthesis. I guess some people might even ask, could you put another transcatheter valve in there? Is that even sensible?
Yeah, I highly doubt that. I mean, with a 23, I think the area inside is probably less than 300, and just imagine putting another valve inside; it's going to be pretty small. So TAV in SAV. How realistic is that? I think if the original valve was 29, maybe, I think you should be able to do so. But 23, that might be hard, in my opinion.
So the size of the original valve matters. Now, the other issue is there's been a lot of debate, as you talk about TAVI explants, he's got this tall valve now because he had this Evolut valve to try and improve the hemodynamics, right? In putting a sort of smallish transcatheter valve inside a valve. And what is the difference? Are there more risks in TAVR explantation for a taller valve than a shorter valve?
We looked at this pretty extensively. In all the registries, there's really no differences in mortality. The only difference, though, is that for the tall valves, they have higher risk of needing ascending aortic replacement just because they're touching that aorta. So the type of surgery does change a little bit based on how stuck it is and where the adhesions are. But the surgery does become a little more difficult with tall valves. But in terms of the operative risk, that has not been shown. And also to add, when you do an explant in the TAV and SAVs, after TAV and SAVs, their procedural risk does not seem to be, that high compared to standard TAVR explant. And I think it has something to do with, the taking out the valve part is not that hard because it's just attached to the surgical valve. It just comes out relatively easily. So there's some different nuances on the type of the surgery when we do it on TAV and SAV versus the TAVR explant.
So it sounds like actually taking out a valve in valve within surgical valve TAVR may be less of an ordeal than actually taking out a transcatheter aortic valve put in for the first time.
It's a little painful because you have to take out the TAVR valve and then you have to take out the surgical valve. So it's additional step for us. But, in terms of the difficulty, technically, taking out the native TAVR will be a little more challenging. Although I don't know if that's going to be true in the future, quite honestly.
Well, I think this has been a great discussion, guys. I think these issues right now are very hot in terms of of this risk of redo explantation, these kind of clinical decision making. To conclude, Yoshi, what do you think is going to happen? And things that developments are very rapid. What do you think might be happening in the next 5 years on the horizon that may be changing, perhaps how we may see this equation?
Yeah. I think in 5 years, what we're going to see, the most important studies that we're going to find out is a 10-year follow-up of Partners 3 and Evolute low risk trials. They're going to have a 10-year data, hopefully in the next 2-3 years. And I think that's going to create a lot of discussion no matter what the results show. And I think that may really shift the way that we practice. If I were to guess, probably more heavy on the TAVR side. I think we just have to be very critical on some of these decision makings, including the surgical side as well. The surgical side, you probably have heard of the Inspirus valve. At ATS, they just reported the 10-year outcome of Inspirus valves. But, are the endpoints really the similar endpoints at the VARC3 criteria? The answer is no. And I think we just have to be very critical in seeing some of these data to guide our practice. And I have a feeling that in 5 years, the pendulum is going to swing even further to TAVR, but it's probably going to return at some point in the middle.
Yeah, so for those who don't know, the Inspirus valve is a TAVR-friendly surgical valve where the base of the valve can be expanded, right, to accommodate a larger transcatheter prosthesis, so you don't get caught in the Russian doll scenario.
Yeah.
And how is it looking for that valve? You're saying, is it good?
The outcomes have been good because they use the Resilia. That's the other features, the Resilia tissue, which a lot of the Australians are probably familiar with the SAPIEN valves. The VFit technology that you're talking about, it enlarges by a few millimeters. It's, I hate to say it, but it's pretty underwhelming when you actually see it. It maybe expands just a little bit. So I don't know how much that's going to really change the play in the future, but it is a very important valve. It's one of the innovative technologies that we have on the surgical side. And I think that valve we have to look at it with critical eyes. But so far, it's been received very favorably.
And the hope is the new Resilia tissue, that future advances in bioprosthetic tissue preparation will lead to the kind of longer duration of our bioprosthetic valves that will become more suitable option for our younger patients. We just don't seem to be quite there yet.
Yeah.
Now, Yoshi, we've seen prototypes or startups presenting technologies where they're trying to cut out the bioprosthetic leaflets endovascularly, like mulch them, and pull them out to make space for a redo procedure. Do you see actually a feasible role for these kind of approaches?
I mean, really don't know what's going to happen in the future. I don't know if people believed 30 years ago that you'd be able to put a valve through the groin. So you never know what's going to happen. But I think the problem about the excision technology is that once you resect that valve, you're going to have a major hemodynamic instability. People have been talking about putting a temporary valves to mitigate that. But none of these mechanical circulatory supports will be able to help that with severe AI. So I think that's a big hurdle that this technology has to overcome, and that might just be too much when the leaflet excision technique, the leaflet cutting technique is much safer. So that might be a challenge for that technology.
Well, Yoshi, it's been a great discussion and talk, and thank you so much for being our guest speaker for this session. And we're very grateful for your time.
Yeah, and again, Martin and Dion, thank you for having me.
Thanks, Yoshi. Thanks, Martin. That's great.
Well, I hope everybody found that informative. I actually learned a lot from Yoshi Kaneko, from his very informative talk, and then our subsequent discussion, Dion. And look, I apologize for running over time. When we recorded that talk, we thought about cutting out the third case, but really we found that in running it in full, having the back and forth discussion was really a good way to learn about these decisions. And I hope that you found it just as informative as I did. Dion, we have a few questions in the chat, and I think that maybe we might look at answering some of these questions as relevant to look, for those people who are still staying on, and I'm sorry we're running late. We'll try and answer some of these questions. I mean, one question is, what concurrent significant asymptomatic silent or bystander coronary disease identified on routine angiography should one fix the focal stenosis prior to TAVI or afterwards, or wait for symptoms? Dion, what do you think about that?
Yeah, that's a fantastic question. Again, it will depend on the anatomy and a combination of how complex the coronary stenosis is the patient symptomatic from it? We used to think traditionally that you had to fix, you wanted to do as good a job as that would happen in the setting of coronary artery bypass graft surgery plus surgical aortic valve. But now we know many stable coronary artery disease lesions can be treated medically. So I think there's been a shift to more conservative therapy. There have been some randomized trials that are just starting to answer this question. A few have come out, and then there are a few ongoing. And so I think for more distal stenoses that you don't think portend a lot of territory, then treating them medically is very reasonable. For severe proximal LADs, large proximal dominant rights, I'm usually still fixing them. But I may often do it after TAVI, in particular if I'm using a low frame valve, such as the Edwards valve, that gives me ready access to the coronary arteries. There can be some benefits to do the TAVI first, in particular if you need to do calcium modification with rotational atherectomy, or a more complex procedure can often be safer when the TAVI is done. So there are some subtleties in decision making. But yes, any option from PCI pre-medical management to PCI post can become reasonable.
I think that if you go through the randomized trials, of which there's several at this point, with or without FFR, the results are conflicting, with some good trials showing reduction in events and other trials saying no. I think at the moment, aside from the lesion location, age plays an important thing. I think that in our practice, we're far more aggressive with revascularizing major epicardial lesions if the patient is young. And however, if you're less active and you're in your late 80s, medical management, I think, becomes more prudent, particularly if the complication of PCI is high.
And then there's a nice question on aortic regurgitation. In pure aortic regurgitation without any calcium in the leaflets, our current TAVI valves available in Australia are not suitable. There is a few valves that are not yet available in Australia that will make TAVI suitable. It's important to know the MBS is restricted to aortic stenosis for the TAVI procedure, in particular within the private sector. It's different if you have mixed aortic pathology. So if you have a bit of stenosis with more dominant AR, then no, many centers will be offering TAVI if it's suitable, anatomically suitable. And another good question about bicuspid. Again, it all comes down to the anatomy. If you're a young, complicated, heavily calcified bicuspid patient, Martin had that great case 1, that's much more suitable for surgery. Whereas if you're an older patient with bicuspid that doesn't have high-risk features, then no, many of us are offering TAVI to bicuspid patients that are anatomically suitable, and we're getting very good results.
There's a good question. Some cases, one can't be sure on echo about valve morphology. Can partial raphe functional bicuspid valve, can it be feasible, TAVI feasible? I guess we should answer that. Will CT shed light in morphology? Well, the answer is absolutely yes. So it is common that we have difficulty even working out whether a valve is tricuspid or bicuspid on TAVI, on echo, depending on the patient's body habitus and so forth. And CT really is very clarifying in the vast majority of cases to, characterize the anatomy of the valve, whether they're bicuspid or tricuspid or what type of bicuspid, and then importantly, stratifying the risk in terms of whether this is a TAVI safe valve or bicuspid valve, or should really, it's a TAVI high-risk valve and surgery would be highly recommended, like the case we've shown.
And then maybe just before we finish, a question about asymptomatic octogenarians. Again, they're really controversial. We know the guidelines are around severe symptomatic AS. I think the trouble is, we see this a lot, 82, 83-year-olds, no symptoms, gradients in their mid-40s, do you just sit and wait? The problem is once your gradient's above 40, they will not be able to have any other procedure without their aortic valve being dealt with first. So if you leave them and they end up needing their urgent appendix or their urgent knee replacement or a cholecystectomy or anything else, it becomes really complicated. So increasingly, for my patients with gradients above 40 and in particular above 45, I don't think there's very little to be gained by more surveillance. You can end up putting your patients in a real mess when it comes time for them to do something else or an overseas trip. They want to go on a cruise and they got a gradient of 45, and then they end up with heart failure. They're not insured because they've got a aortic valve condition. So I think increasingly, in particular with higher gradients, I have a much lower threshold to recommending intervention.
On that note, Dion, I think we should probably close up. Thanks for staying on, maybe 20 minutes later than our proposed end date. I hope you've end time. I hope you've enjoyed this evening with Yoshi Kaneko, Dion, and I. I certainly learned a lot in this, and thank you for being part of this evening of Lifetime Managed Aortic Stenosis. Good evening.
Thanks, everyone.
Thanks.